Go. All right. Good afternoon, everyone. Thank you so much for joining our Talk on Race series. Maternal health is our topic for today. As always, we start with our land acknowledgement. The Lower Cape Fear YWCA serves the people located within the Lower Cape Fear region. This land once thrived with life from indigenous peoples, known today as the Cape Fear Indians and the Waccamaw Indian people, living in established settlements along the Cape Fear River and Lake Waccamaw, along with many other established sites in the region. We need to protect and honor the history of these places. Indigenous people are not relics of the past, they are still here, continuing to demonstrate their talents and gifts amidst the backdrop of ongoing colonialism and oppression. They are worth celebrating. We hope our land acknowledgement statement will inspire others to stand with us in solidarity with Native nations. Again, thank you so much for joining our Talk on Health Maternal, our Talk on Race Maternal Health. I am joined by three amazing women who are in the industry and who are health experts. We will start the conversation. If you could just say your name and your role and what organization you work from. So we're going to start with Dr. ODIBO.
My name is Dr. IMELDA ODIBO. I am an OBGYN, and I specialize in maternal fetal medicine. So I manage high-risk pregnancies that are high risk either because of the mom, medical complications for the mother or for the baby. And I work here at Atlantic Fetal Medicine, which is part of the New Hanover physician group.
Thank you so much for joining us. And Dr. Gaskins.
Hi, good afternoon. I'm Dr. SHERITA Gaskins. I am an OBGYN. I am a generalist, meaning that I do not take care of high-risk patients, at least not without the help of maternal fetal medicine specialists like Dr. ODIBO. And I am joining you all from the Maryland region. I am a hospitalist at Baltimore Washington Medical Center. And then I also work as a medical director for a managed care company.
Thank you so much. And then Miss Marissa.
Thank you, Jhaniqua, for having me. Am I echoing?
No.
Okay. I'm Marissa Bryant Franks, Health Equity Outreach Coordinator here at NHRMC or Novant Health now. Also leading First Year Cape Fear, which is an organization dedicated to improving birth disparities and birth outcomes for Black women here in our area. So thank you for inviting me. Glad to be here amongst these wonderful two ladies.
Yes, thank you. And thank you both for taking time out to talk about this important conversation. So if possible, let's start with the basic definition of what exactly is maternal health.
Well, I think of maternal health as kind of all-encompassing, the physical as well as the emotional health of women during pregnancy, during, childbearing years mostly. So like even the prenatal period, during pregnancy, the postpartum period as they're becoming new mothers.
Yeah, okay. Yeah, go ahead.
To add to that, the typical definition for maternal health would be, okay, the health of a mom during the pregnancy, childbirth, and postnatal period. But I find myself as a high-risk OB doctor having to talk to women a lot about what happens 2 years down the line, 5 years down the line, 10 years down the line. If you have diabetes now, gestational diabetes now, how is that going to affect your lifetime risk of having type 2 diabetes? If you have preeclampsia now, how is that going to affect your lifetime risk of having cardiovascular disease? So it's not just maternal health. I think I agree with Dr. Gaskins. It's all encompassing, and it's not just limited to that peripartum period where you're having a baby. It impacts our entire lifetime.
And
Wow.
actually, I would like to add to that as well. I think it even begins before they become, or it should begin before they become pregnant, because the more people understand about the need to maximize their health and maybe address some of their chronic conditions before becoming pregnant, it really has a significant impact on the quality of the pregnancy.
Yeah, I would
Absolutely.
say when I first met Marissa, it was through the what was before the Infant Mortality Task Force, where we were kind of gathering research and studying why the disparity kind of existed and what that disparity looked like in our county and surrounding areas. And I think it was at one of those meetings that I discovered that there is prenatal care, like the care before even conceiving. And I don't think we actually have that conversation. Usually people are like, okay, it's time to have a baby. Let me get the little app, figure out, when I'm fertile, and like that's it. But there's actually care that needs to happen for a woman's body before. So if someone could talk to that, I would love to kind of hear and explore what that care looks like.
Absolutely. I typically love to have patients for preconception care, preconception counseling. That's what it's called.
Okay.
And I encourage the OBs that we work with to identify any issues and have the patients see us before they even get pregnant. Absolutely. We want to, at that visit, we want to definitely explore things like exercise and diet, their weight, any chronic problems that we can optimize. For example, if you have diabetes and your hemoglobin A1C, which is one of the ways that we monitor diabetes in the general population out there, if it is 10, no, we don't want you having a baby right now. You are at increased risk of having a baby that may have malformations like cardiac defects and things like that. So we want to work with you so that we can get your hemoglobin A1C down, get your glycemic control optimal before you can attempt pregnancy. Do you have high blood pressure? We want to get you on a blood pressure medication that is appropriate for pregnancy before you attempt pregnancy. We want you to be on your prenatal vitamin. We want you to be on folic acid. There are a whole lot of, if you want to lose weight, that's the time to lose weight, to try to get a little healthier before you become pregnant. So yes, that's a conversation we would love to have with a lot of women prior to pregnancy.
Yeah.
To add to that, Jhaniqua, I was just going to speak on kind of the public health perspective when we look at equity and we look at the way that our communities are structured. I think that there are a lot of disparities because people don't have access to proper nutrition or infrastructure in order to exercise. So these are things that kind of feed into the outcomes that we see prior to mom getting pregnant. So I think that that's something that we have to definitely consider when we talk about preconception health and interconception health, in addition to the education aspect, because I think a lot of people aren't aware of what it looks like to take folic acid even before your pregnancy, right, Dr. ODIBO? So usually, you get pregnant and then you say, okay, now I'm going to take my prenatal vitamins. But I think that we have to do more education around what preconception health looks like and how to make that happen when we have limited access to resources.
Marissa, I think also that, there also needs to be some consideration to women's access to care during that time, because a lot of women are on Medicaid. Your Medicaid doesn't kick in until you become pregnant. There is no coverage for the preconception period. And, unfortunately, that's really a thing that is missing in our society.
Yeah, absolutely. And to your point, I think that we have to really examine that, number one, and then look at the way that our Medicaid system is structured. So after your pregnancy Medicaid expires, if you don't have access to a primary care provider or you fall in that Medicaid gap and you are back without any type of insurance or coverage, to make sure that you have access to someone who can treat your conditions and make sure you're taken care of in between pregnancies.
Absolutely.
Yeah, and how do women begin to advocate for I guess that prenatal and postnatal care, especially if they are already challenged with access. What could that look like? What does that look like?
I think it may look like community organizations, taking an active role. It's really difficult to engage with physicians or the healthcare establishment as it is if you don't have insurance, if you don't have the access. I actually work with some community and faith-based organizations, and we are looking to, give health education, because if women don't know the risks that they have, many women don't know that it's a good idea to see a doctor before you become pregnant to try to get your blood pressure under control and get your diabetes under control, and find out about family history, or find out what happened to you in the last pregnancy, because all of these things are important pieces of information to tell us how safe it is to become pregnant. Part of the problem, I think, is that just as a society, we undervalue or we don't understand how dangerous pregnancy can be for women.
Mm-hmm. And we have a comment from the audience that says, if you're a disabled veteran, the VA will pay for your prenatal care, birth, and your child's care for 1 week after birth. So I guess the VA is trying to tackle that part of the access for women. So thank you to that comment. And I kind of also want to explore what Black maternal health, Black and Brown, Black, Brown, Indigenous maternal health looks like. Because if you look at the disparities, they're so drastic. Black women, they miscarry more than white women. Their lower birth weights. What else are some of those maybe disparities that you come across or you see you are working with Black and Brown women?
I'm just going to start by saying that when I was in medical school, and just for everyone, I didn't grow up here in the United States. I grew up in Nigeria. I was maybe 21. I was done with college already before I moved here. So I moved here and then I went to medical school here. And I can remember, I don't know, Dr. Gaskins, what your experience was, but I sat in the classroom every single day as we went through risk factors, and I felt, oh my God, who do I have to be to have a good outcome as in pregnancy? And I ended up with, you have to be white, you have to have a college education, and you have to be married.
and it doesn't, and it will not hurt to have a little money. Little money doesn't hurt.
Yeah.
So that was disheartening to me as a Black woman to think that I wasn't in the group that is expected to have a good outcome for anything in pregnancy. There are a lot of disparities in maternal death for us. We are 2 to 3 times more likely to die from pregnancy and pregnancy-related issues than our white counterparts. In preterm birth, that's another one, more than 1.5 times more likely to have preterm birth. Other things like infertility, unintended pregnancies, STDs, even some forms of cancer. Maybe Dr. Gaskin can speak more about the general gynecological things. But yes, it is the statistics are staggering for African-American women and Black women.
I wanted to add to your comment, Dr. ODIBO. Thank you for highlighting your experience in doing the research, because I was pregnant with my first child when we really started getting deeply embedded into this work around first-year Cape Fear and researching the disparities. And at the time, as we were trying to better understand equity as an organization and as a community and better understand infant and maternal health disparities, a lot of the conversation was going into the fact that income must be a determinant for maternal health outcomes. And obviously we know that's not the case. A Black mom who is college educated is more likely to lose her own life or the life of her child than a mom who is white and did not graduate from high school. So when I was pregnant, I was like, wow, kind of nervous, like there was an anxiety associated with it, knowing what I knew, in that just because of the color of my skin, I could be discriminated against and I could receive subpar care and something could be wrong and I don't know, or my family doesn't know, and things could go wrong. So I think it's really important to highlight that. And a lot of people do think that income is a determinant, but I think that race is what we're looking at. So racism is the issue here, not necessarily a risk factor, I think.
Yeah. Dr. Gaskins, do you have anything to contribute?
Yeah, I mean, I agree with that for sure. And also it's just the, what was I gonna say? I lost my train of thought. We're talking about income. I'm sorry, let's move on. I've lost my thought.
No problem, no problem. I think as a Black woman, as a woman of color, when I think about the disparities, where's my hope? What kind of experiences should I be having when I go into the doctor's office? So, I'll give an example. I have a son, and I had a list of questions going into his physical exam. Like, I want to know, I probably honestly had about 10 questions. And, I really wanted all 10 of my questions answered concerning my child. And when I was done, the physician was like, "Are you finished?" And I at that moment, there was something in me that said, I don't think that response is right. And I wonder, when women of color come into offices, whether it's prenatal, postnatal care with their children, when they feel like their care is subpar, what are some of the signs, other than maybe that internal, like, I didn't like that comment?
I think if you don't feel heard, I think that's a big thing. And that's a problem with a lot of physicians. And, and it's just it's the system. The schedules are tight. You're kind of pressured to hurry so you can see the next patient. But if you don't feel like the doctor has heard what you said, has really addressed your primary concern or your list of concerns, even, maybe they don't have time to answer all 10 questions in that moment, but maybe they can say, email me the list and I can, address them by email, or let's set up a follow-up appointment to continue. Let's stop here today because, I do need to move on, but, let's move on. Let's address these other questions, because it is important to be your own health advocate. No one's going to do that better than you. For Black and Brown people, it's important to have doctors that look like you. And that's hard in a lot of communities. I know you all were telling me that Dr. ODIBO is the only show in town.
She is.
As far as,
and we're going to talk about that.
That's a big problem, because health outcomes are better for women when they are taken care of by Black OBGYNs, when they're taken care of by Black midwives, but when the babies are cared for by Black pediatricians. So, it matters, and I do think it's because of the connection and the comfort of the community.
Yeah. And Dr. ODIBO is the only woman of color high-risk specialist, OBGYN, in the Lower Cape Fear. So one, we have to say thank you for joining us, because as that position, what her schedule looks like, right? But also, I can't imagine the amount of pressure that you also feel when you are practicing, and as you are helping, women of color deliver babies in a high-risk situation. So, 2 questions for you. One, how do you work through some of that pressure? And then 2, could you appeal to the community to recruit more women of color to practice in the area?
Absolutely. So when I was recruited here, I remember coming down to visit, and I had lived and did my, medical school residency and fellowship in bigger university level institutions. So it was never an issue. I had other people that looked like me, it wasn't such a big problem. But when I came to interview here, I realized that there weren't a lot of people like me walking around, period. So after the first visit, I requested to return, and Marissa, you must know Dr. Bestie. I requested to return, and I asked him, I said, you have to find me some Black people, okay, for my next visit. I want to see them. I want to talk to them and see what life is like in Wilmington. He did. He did. He found me. He found me some colleagues at the hospital now that I've remained friends with, that I met when I came here, and they're like, you need to come here. We need more of you here. We don't want you to shy away from coming, because you have to be the change that you desire, right? So when I came here, there were two of us, and both of us were women of color. We had just graduated from fellowship, Dr. Fu, who was the reproductive endocrinologist. But again, there was still a gap. Both of us were specialists, and women will email me all the time and call my office because they think I'm a generalist. You know, they want somebody to take care of, you know, their everyday life. And I can't, you know, as I was saying before, I just take care of high risk pregnancies. So you don't only have to be pregnant, you have to have a problem. I'm sorry, but you know, there has to be a complication. Not that I want you to have a problem, but there has to be a complication. So it has been very challenging for me. Not just to be the only woman of color, but I feel short because I feel like I can't even serve all of my women. I can only serve this small number of them. So it's been hard. And I have I'm trying now. I have talked to people that matter, and we're going to continue to advocate for them to be deliberate. It's not enough to say we have an opening in our practice, and you have to be, if you want to recruit someone of color, you have to be deliberate. You have to actually do something about it. You can't just post the position and then sit back, because you're going to get white applicants again, because that's what happens. So we're trying to figure out ways to be a little bit more targeted, and to see if we can get more people of color that can take care of women in our region.
And I mean, the interesting thing about that is that we continue to have these conversations about people of color, there being few and far between when we're talking about education and needing to recruit more teachers of color, because the statistics say if a Black or brown child has a Black or brown teacher by 3rd grade, they're more likely to go to college. And so, you know, you're right, it has to be an intentional recruitment. Since we're live, I would say HBCUs are a great place to start, because it's a historically Black college. And what do you find in historically Black colleges? You find Black kids, you find Black students, that's where they are. That's who we are. And so I always have to put that out there. But Marissa, thinking about Dr. ODIBO's position, thinking about Dr. Gaskins, as you are a health equity worker, you know, what are the ways in which maybe you also come across the gaps of care for people of color from physicians of color?
Well, one thing you said, Jhaniqua, about your personal experience with taking your son to the doctor kind of triggered in me something that we discussed a few weeks back in working with UNCW. One of my colleagues there, who's a professor, a woman of color, she was mentioning how she, for instance, will dress a certain way to attend her doctor's appointments to communicate her status almost. And it's funny because when she said that, I thought of Black women that I know, who I grew up with, like aunts and grandmas and older women, and they would always get dressed up nice to go to the doctor, right? And I'm thinking, why should you have to do that? When you get there, you typically have to take some of your clothes off anyway because you're doing an exam. I didn't understand it, right? And so the more we dive deep into maternal and infant health, and we look at bias in care, and we look at the importance of having a provider that can provide culturally sensitive care and understands you and understands your questions and knows how to respond to you, that becomes more sensible to me. So you shouldn't have to do that. That's not something that should have to happen. But it's sad that women have to communicate their status or appear a certain way to receive a certain level of care. And even then, still dressing up is, you know, not always enough to even receive the respect that you already deserve from your provider. So that goes back to the importance of providers of color. And I think you're exactly right. We do need more representation in all of these fields because they all intersect when we look at infant and maternal health outcomes. Education, housing, all those things really play into the outcomes that we see. So looking at the bigger picture, I think you're exactly right. We do need more representation.
Yeah, and one thing, and Dr. Gaskins, feel free to jump in. One thing we were also talking about a little earlier was the misconception that physicians of color are not physicians. You know, like you walk into the room and you want to share your experience. I think it would sound better coming from you.
Yeah. I mean, anytime you walk into the room, they assume that you're anybody other than the physician. It's as though their mind can't conceive of a Black female physician. So even if you have the badge on that says doctor, you've just done their surgery, you've just examined them, whatever, you know, you can go through that whole process. And then they'll look at you and say, well, and when's the doctor coming to see me? And it's like, well, who did you think I was? You know, if I wasn't the doctor. And I'll give you a really egregious example from medical school. Some of my classmates of color and I, we were in our gross anatomy lab. And so in gross anatomy, you dissect a human body, a human cadaver. And so it was a Saturday during Parents Weekend. We're all centered around this cadaver. We have our textbooks, we have on our scrubs. We're studying for an exam. One of my white classmates walks into the lab with his mother, and his mother looks horrified. And she says, oh my God, they let them handle the bodies like that? And he's like, what are you talking about, Mom? And she says, the cleaning people, they can handle the bodies like that? And he turns beet red and he says, Mom, these are my classmates. But we're there in scrubs with textbooks around a cadaver, and somehow this woman thinks that these are the janitors. Why would the janitor have a textbook, with the cadaver? Why would that even be? But like I said, it's like a cognitive dissonance. Their brain just can't even conceive of such a thing. And it's really, Dr. ODIBO talked about feeling badly about not being able to take care of everybody. It's exhausting to be in this, in this position, because you do want to help everyone. And then on the other side of it, you're dealing with all of these sometimes micro, sometimes macro aggressions that come at you from the medical establishment or from even the community.
Mm-hmm. Yeah. I think the interesting thing is, as we have completed the talks on race, the one thing that is very clear, and Marissa, you said this earlier, is that race is always a factor. Me being a Black woman is always a factor. It's a factor in my care. It's a factor, if I'm in the doctor's office, if I'm in the hospital, if I'm at the schoolhouse, if I am involved in the criminal justice system, like race is always an interwoven factor. And so we're going to pivot a little bit. How can cisgendered women take better care of their bodies? When we talked about prenatal care, postnatal care, what can we, I am a cisgendered woman, what are the ways in which maybe, I may not be able to go to the physician and feel comfortable about asking, certain questions, but, what are maybe some tips to kind of help us take better care of our bodies?
I would say one of the first things is to start with diet. They always say you are what you eat. And that's more true than people realize. And we as an American society have a horrible diet. I'm sure Dr. ODIBO, coming from Nigeria, probably got here, was like, what do these people eat? Why are they eating this crap? Because we come up on crap, and it's getting worse with each generation, to be honest. So it starts with having a healthy, well-balanced diet, probably largely plant-based diet, having a healthy weight, getting exercise, getting adequate sleep, taking vitamins, managing your stress. We don't talk enough about the stress of racism in this country. They've had studies that look at, let's say preterm labor for, or what am I trying to say? Small babies, the size of the babies. Women who come up in this country who were born here have smaller babies than women who come from other places. And it has to do with the racism, the stress of racism. It does something to our bodies. They have studies now that show that it actually changes our DNA.
I love that you mentioned that, Dr. Gaskins. I thought that study was amazing, especially going back to how some of this research developed. And at one point in time, people were saying that Black women had longer nerve endings, or they they had some type of genetic defect, and that was what was causing babies and women to die. And so I think that's really important that you highlight that, is the stress plays a huge role in a lot of the outcomes we see. And just being Black every day, or being a woman of color every day, can be very stressful.
And it can happen to anybody. You know, when I have one child, and after I delivered my daughter, I became very sick. And even me, you know, you would think if anybody could get good care, quality care, competent care, it would be a doctor, right? You know, and I'm, you know, and I hate to say this, I was being taken care of by my own practice in my own hospital, and I was very sick. And you know, it became this thing of the nurses are calling and they're telling my partners, I wasn't aware of this at the time, you know, Dr. Gaskins won't get up. She won't take care of her baby. She's a slug. She's a this, she's a that. And it's like, wait a minute, if anybody knows that you need to get up and move around after a delivery, a C-section, it's me. If anybody knows these things, it's me. So, you know, why do I have to be my doctor and the patient at the same time? And so it ended up that I had something called an ileus, where my bowel had gone to sleep, but it wasn't recognized. And I was getting sicker and sicker and sicker until finally, you know, I was praying one night. I was, God, I'm getting so sick and nobody's doing anything. You know, you have to help me. And it came to me, you have an ileus. So I called my partner. Long story short, I actually had that. But, you know, had I not, you know, been able to run a differential, you know, like a list of things that could be wrong in my own mind, had I not had access to the doctor immediately on my cell phone to call and say, hey, I have this thing, you know, can you get this scan so we can figure this out? What would have happened to me? You know, we had in the same area, I had a pediatrician colleague who is not an OBGYN, not a surgeon. She had just delivered twins. She had something similar. They sent her home. Her bowel ruptured and she died. So, you know, it can happen to any of us, you know, because again, there's like a judgment that's placed on you. You know, when the nurses say you're a slug, that means you're lazy. That means you don't want to cooperate. That means you want everybody else to take care of your baby. And that couldn't have been farther from the truth. Instead of thinking, okay, something's really wrong. She's not walking. She's not doing this. She's not doing that. You know, instead, there's a judgment that's placed, I think, on Black women a lot of the time.
I just wanted to add that, as we said today, it's really important for women of color to know that there's nothing wrong with us. The Human Genome Project clearly demonstrated that our genes are all the same, white, Black. There is nothing wrong with us. There's nothing inherently wrong with us. Even, and as we said before, even when everything is controlled for income, socioeconomic status, we're still having bad outcome. That means something is happening. People are not taking us seriously. We're not being diagnosed as early as we should be, because people are dismissing our symptoms and signs and our complaints. There are these preconceived misconceptions about us. There was a survey of medical students at a prestigious university, and they thought Black people, because we have melanin, that we weren't as, we wouldn't feel pain as much as a white woman would. These are medical students. There are a whole lot of misconceptions. There are the microaggressions that Dr. Gaskins referred to. People are doing things to us. There's nothing wrong with us. Mm-hmm. People are imposing these beliefs and biases that is actually leading us to have bad outcome. And it's time to sit up and address those and hold hold people accountable, be it healthcare, be it your doctor, be it our government. We need to be held, they need to be held accountable for what's going on with Black women.
Absolutely.
I have a t-shirt, just to interject really quickly, a t-shirt that says there's nothing wrong with Black people that ending racism won't cure.
Woo! I need some
Love
claps,
it.
some drums, something. Yes. Yes, I think because when you think about disparities across the board, again, we go back to the underlying factor, which is race. So questions for the two physicians on the panel today. What do you implement as healthcare providers that keeps you from kind of doing those that people do, which is like being dismissive or, you know, writing things off like, oh, it's not that serious. How do you embody that in while you are practicing?
I value each person and I value each life. And I understand, the way that I was raised in medicine is how I'll put it. The way I came up in medicine is that you're going to learn the most about your patient by what they tell you, not by what you examine, not by the blood work, but by what they tell you. And I have to listen very closely, because if I'm not actively listening to you and actively processing what you're saying, I'm going to miss something, and something bad is going to happen. And so I think part of it is in understanding that that's the case. And then understanding that, again, that everybody has value no matter what their situation, whether it's someone with mental illness, because we have that not infrequently, where there are women who come into labor and delivery all the time because they have mental illness, or they have housing insecurity or food insecurity or whatever. They're coming, and so there's a perception, they're coming just to eat. They're coming just so they have some place to be overnight or whatever. But I always tell the nurses, just because they have these other issues, it does not mean they cannot be sick. And so you still have to listen to what they're saying and still have to run all of the tests that you would ordinarily run, because if you don't, you're going to miss something. And I think, unfortunately, not every doctor had that kind of training. And quite frankly, to some extent, not every doctor has that kind of heart. Everybody, wants to, you want to blame people for their circumstances. And, as all of us, I know I'm preaching to the choir and talking to, you three lovely ladies, but, we know that it's a societal problem. It's a systemic problem.
Mm-hmm.
A lot of what goes on with people, it's not them, it's their situation. You can't be what you don't see. I think there's a documentary that I saw this weekend, Black Men in White Coats, that talks a lot about the disparities and the fact that there's only 2% of physicians in the country that are Black men, that there are less Black men going into medical school right now than there were in the 70s. And that's completely unacceptable. Yeah. And Black men have the worst health outcomes of all in this country. Lower life expectancy, more comorbidities and other things. And so, it takes compassion, but it also takes, I think the younger generation being able to see us, to see Black women, see Black men, and, be able to aspire to become doctors, and for the community to hold doctors in a place of, some regard. We kids always want to be basketball players or, football stars or rappers or actors or whatever. But how about, wouldn't you like to be a doctor? Look at what you could do for the community.
Yeah.
And I just wanted to add to that honestly, Jhaniqua, I actually love patients like you who bring a list. Manage high-risk pregnancies and everything. There are a million things to talk about and tease out, and it's always good to be organized and to kind of take them one by one, because honestly, I learned the hard way that if that is not done, it ends up taking, and talk about time, usage and efficiency. it ends up taking much more time because the patient goes home and they don't understand the thing that happened during that visit, and sometimes they send you a million emails after that. They call the office, they come back, and you have the same conversation over again. So when I see a list, I'm happy, and I go over it. And I just want to point out that there's a difference between dismissing a patient and not taking what they're saying seriously and reassuring. For example, in pregnancy, you know, we have some patients who have what we would call discomforts of pregnancy, you know, like, and you have to be a compassionate physician, as Dr. Gaskins said, and tell them, you know, kind of explain that, yes, I don't think it's this, let's run this blood work and make sure it's not your thyroid, or you're not anemic, but fatigue is actually something that does happen during pregnancy. But you have to assure that patient that you're taking good care of them, that you're looking at all sides, and then you reassure them. And that's, you know, that I found that helpful in my practice for sure.
And I guess, Marissa, thinking about it from the health equity aspect, how do you advocate for your patients to kind of, I guess, be heard in the healthcare environment?
Yeah, a lot of what we do out of our department is centered around trying to educate our providers on how to be more culturally competent, how to avoid bias in care, and how to actually listen to your patients. Some of that has actually also dived into microaggressions training and really understanding the cultural aspects of it. And I think another part of our advocacy is really educating patients on what questions you can be asking your physicians, how to have the dialogues of the uncomfortable conversations. Often people don't want to have a confrontational relationship with their physician because you've got to come back and see this person, and they're treating you for a whole 9 months sometimes. So teaching them how to navigate the dialogue sometimes so that they can get what they need out of the conversation and feel more reassured, regardless of if the physician is checking all the boxes like Dr. Gaskins and Dr. ODIBO are. So I think that's a big piece of it, and also really getting a chance to understand the perspectives of moms. That's something we're still in the process of doing. So getting firsthand accounts of what experiences are like and what needs to be done to really get that care continuity established so that we don't have these issues.
Yes, thank you. Thank you. Well, we are almost out of time, so I have one last question for the panelists. What policies or procedures do you think could be implemented that would assist in creating more safe environments for women of color during childbirth?
Well, during childbirth itself, there are now what we call toolboxes. You know, there's different checklists that are standardized that are being used, you know, to try, because the biggest causes of maternal morbidity or bad outcomes are things like hemorrhage or hypertensive emergency that leads to stroke and seizures and other things. And so now we're starting to try to standardize the care of women when they come into the hospital with those issues, or if they, you know, display risk factors for hemorrhage, that things are ready at the ready for them. So that you kind of take out, you know, some of the biases. If they come in with these symptoms, then they go down this path, and this is the path that we're going to use for them, so that it's not a matter of, you know, you making a subjective assessment, but it's using the objective data of the blood pressure or the objective data of this particular history. And in California in particular, California is kind of the front runner in this, and where they began to develop a lot of these tools. They've decreased their maternal mortality considerably. They actually have the lowest in the country at this point. I think they have 4 deaths per 100,000 women, which is amazing. I think the national average is around 18.
Wow.
You know, so I think using those kinds of tools that kind of take the human bias out of the care, that helps. You know, that's a big help. You know, but again, it's a system-wide problem, a societal problem. So that's just one piece of it. But that's the beginning of helping to get women the care that they need and the care that they deserve.
Yeah,
And I
yeah.
wanted to point out that Marissa mentioned something really important, because I think most of the physicians, most of healthcare providers, I think they try to hide under this umbrella that, oh, we're colorblind. You know, I have friends who have color, things like that.
Yeah.
We don't want you to be colorblind, because
No.
that actually prevents you from providing the care that you need to provide for women of color. No, don't be colorblind. Look at me as a Black woman that I am, that I'm disadvantaged. When I walk into your office, I want you to be conscious of the facts. I want you to choose to value me equally based on facts and not your perceptions of me as a Black woman. So if you're not colorblind, that actually helps us in the long run. So I think training physicians and health providers to be conscious of what's going on, I think is a very good step towards achieving closing the gap on these disparities.
I love
Yes.
those points. Yeah. I was just gonna add one more thing, Jhaniqua. I know we're
No,
out of
you
time, but
enjoy.
a lot of our dialogue, in addition to these standardized care practices and these care paths and toolkits that you're mentioning, Dr. Gaskins, and then Dr. ODIBO, you're mentioning specialized approaches to care. I always ask the question of how we can, bias training is great, but how are we measuring if people are applying that knowledge to their care? How are we holding providers accountable and actually seeking feedback from patients to make sure that the people that we have on our care team are providing the best care possible for all their patients, not just those that maybe are the same color as them. So I think that's another thing to discuss, is how we can establish some type of accountability to actually be able to measure these things and whether people are applying these resources that exist so that we are not providing biased care.
Yeah, absolutely. I think I do want to go back to the colorblind racism. We just here at YWCA is one of the key things to teach when we do diversity training across the board, is that being colorblind is actually, it can be a part of systematic racism. It is part of systematic racism because you see color, and you are like diagnosed and you're actually colorblind, then you actually open your eyes and you see the blue sky and you see the green grass. And when you look at me, you see a brown woman, you see a woman of color. And that has to be acknowledged because I come with history. I come with my people being systematically oppressed. I come with my great ancestors be wet nurses. I come with like the other day I was talking to Velva and she was talking about how her great grandmother was a midwife. Like, we come to the table, we come to your care, lots of history, and that needs to be acknowledged and understood and appreciated, because I think if we start there, then we actually can start at a place to give good quality care. And I think that that's what we all come to the table to do. Y'all went to school for a very long time, practiced on a lot of people to bring good care. And, to get this place where we have discussions on maternal health, because all Black women don't get good care. I hope that in 10 to 15 years, that this conversation won't be needed, that there will be a different conversation, because we will have grown, and healthcare providers would have grown, and would have our systems are educating in a better way and in a more way that is equitable. So thank you all so much for joining us. Thank you, Dr. ODIBO. Thank you, Dr. Gaskins. Thank you, Marissa, for coming to our talk on race to discuss maternal health. I appreciate your time. I appreciate your wisdom and insight, and just the work that you're doing in our community to help women who are going through a prenatal, postnatal journey, that they are provided the best care possible. And so I hope that if you're out there and you are a physician, come to Wilmington.
Please.
Come to Wilmington. Dr. Gaskins, come to Wilmington. We need you. All right. Thank you so much. And I hope everybody has a great day. Bye-bye.
Thank you, Jhaniqua.
Thank you.
Bye.
Thank you.